In this module, we will be focusing on the market for private health insurance. After reading Chapter 8, you should be able to explain how risk aversion and risk neutrality are related to the purchase of health insurance. Describe the economic benefits of risk pooling from the perspectives of the consumer and the insurance company. Discuss the means by which adverse selection can be reduced. Summarize how insurance demand is related to the loading factor. Break down the factors that influence the demand for health insurance and identify the changes that the ACA has imposed on health insurance products. We'll also focus on a number of technical issues, and you should be able to describe the graphical relationship between risk aversion or risk neutrality and utility or satisfaction. Show graphically how expected wealth and actual wealth are related to expected utility and certain utility. Use the appropriate mathematical equations related to income and utility to evaluate the purchase of health insurance. And this is something you've already worked through, but apply a Herfindahl-Hirschman index calculation to draw a conclusion about competition in the health insurance industry. The Nobel Prize winning economist Kenneth Arrow first noted that demand for medical services is irregular and unpredictable. He wrote that the non-existence of markets for the bearing of some risk in the first instance reduces welfare for those who wish to transfer those risks to others for a certain price, as well as for those who would find it profitable to take on the risk at such prices. And economist Thomas Maguire stated that the fundamental purpose of health insurance is to reduce the risk associated with healthcare spending risk, interpreted as some measure of variation of health costs faced by an individual or household. The demand for health insurance really arises from risk aversion, and most individuals are indeed risk averse, especially when it comes to the risk of having high out-of-pocket healthcare expenses. People in general do not like risk. They prefer certainty over chance, and they are better off, or specifically have a higher level of utility with insurance than without. As we'll see later, risk-averse people are willing to pay more than what would be the actuarially fair price of insurance to decrease their worry about uncertain medical expenses. The actuarially fair price is simply the insurance premium given the probability of service use and the cost of the associated service. Risk-loving individuals, in contrast, are willing to take chances. They ought not to buy health insurance even though they're aware of the financial burden of being ill without insurance coverage. And risk-neutral people are right in between. They're neither risk-loving nor risk-averse, and so they're willing to buy health insurance at an actuarially fair price, but they're not willing to pay a risk premium above that price. So, for instance, say the probability of needing a $50,000 health service is 10%. A risk-neutral individual would be willing to pay just $5,000 or the cost of the health service multiplied by the probability of needing that health service to insure against the risk of this medical cost. So when we're thinking about risk pooling, it's useful to think about insurance as a club. Suppose that there's a club of 20 members, each of similar age, interests, and lifestyle. Each year, one member of this club randomly becomes ill and must spend $10,000 on health care. In this case, the probability of illness is 0.05, and each club member therefore expects to spend $500 on health care each year. That's the probability of illness or injury multiplied by healthcare expenses if ill or injured. However, there's also a 5% chance that a club member will spend $10,000 on healthcare, And club members also worry about this healthcare expenditure risk. So they expect to spend $500, but there's a possibility of 5% probability that the club member will have to spend $10,000 out of pocket on healthcare. So the club members decide to collect $500 from each member. And now when one member becomes ill, this fund will cover the member's healthcare expenses. So in this case, each member pays a $500 premium to avoid the risk of paying $10,000 out of pocket on healthcare. So in this sense, we've pooled the risk of incurring that $10,000 of out-of-pocket healthcare expense, and given that probability of illness and healthcare expenses bill, the actuarially fair premium for this club would be $500. And that is what's collected from each of the 20 members. That will lead to $10,000 in this fund. In the U.S., we have a few major health insurance clubs. We have employment-based clubs, and those clubs are financed by employers and employees through premium contributions and also cost-sharing requirements like deductibles, co-pays, and co-insurance, which are paid by the employee out of pocket. We also have other private clubs, including those established by the Affordable Care Act. So the ACA marketplaces are financed by individuals, so they pay for their premiums out of pocket. But many of them also receive tax credits from the government, depending on their income and eligibility. And lastly, we have public clubs, which include Medicare, Medicaid, CHIP, and programs for military families and veterans. These are also financed by taxpayers. However, we still have around 8% of the population without any form of health insurance coverage. More than 20 million people in 2019. And so one argument is that we need to have expansion in either employer-sponsored health insurance coverage, private health insurance coverage through the Affordable Care Act, or a public health insurance coverage to expand coverage to those who are uninsured or underinsured. And this dovetails nicely with what's presented by Uwe Reinhardt in his text, looking at how healthcare is ultimately financed, whether that's through taxes that are collected by the government or through insurance premiums paid by employers and employees, or whether it's through implicit wage cuts for employers as well. This is how we're pooling all of these funds, which then go to reimburse providers of care. However, this is especially problematic right now amid the COVID-19 pandemic, given that many people have lost their jobs, and with it, they've lost their employer-sponsored health insurance coverage. So some individuals elected to have the COBRA extension for their employer-sponsored health insurance coverage. But we also saw a lot of people lose coverage overall, and as these charts from the economic policy suggest, as workers become unemployed, their probability of becoming uninsured rises substantially. And so they note that a new government survey measuring the economic consequences of COVID-19 indicates that for every 100 workers who were covered by employer-sponsored insurance before losing their job, only 85 retained access to some form of health insurance in the week after they lost their job. This is especially problematic given how we've pooled risk for healthcare expenditures in this country, because when you have a predominance of employer-sponsored health arrangements, people lose their jobs, they also lose their insurance, and that's arguably when they need it the most. So the uninsured rate in the country is still around 8%, but that varies by demographics and age groups as depicted by this chart. So what is the price of club membership? That's the health insurance premium, and the total premium is composed of the actuarially fair price and also a loading factor which reflects the cost of doing business, including planned marketing, profit, human resources, and building expenses. More formally, we can think of the premium for a health insurance policy as being the following. Here, given this formula, L is the loading factor, and this includes the cost of administration, marketing, claims processing, profit, and maybe even the hedge against adverse selection or moral hazard. C is the coinsurance rate. This is the portion of the bill paid out of pocket by the patient. And PQ is the expected loss or the expected average medical expense. Here we're assuming that there's no deductible or other forms of cost sharing aside from the coinsurance rate. And the deductible would be changing this formula because that's the amount of money that the insured must pay for services received before the insurance company pays any portion of the bill. But there's no deductible here, and that's kind of collapsed into the coinsurance rate as it's specified here. For instance, if L, the loading factor, is 0.1 and C, the coinsurance rate, is 0.2, and the expected loss, P times Q, is $10,000, then the annual health insurance premium would be $8,800. So we would have 0.8 times 10,000 covered by the insurance company, and that would be the expected loss for the insurance company, given that $2,000 will be paid out of pocket by the individual for $10,000 incurred expense. And then we would have the loading factor of 0.1, which is basically the markup on the actuarially fair portion of this premium, and that will lead to a total premium of $8,800. So what is the typical loading factor for the U.S.? Reinhart notes the following according to a recent publication by America's Health Insurance Plans. Private health insurers on average take a haircut of about 17.8% off of the insurance premiums paid by employers and employees for operating costs, which means marketing and administration. Another 2.7% goes for profits. That haircut was as high as 45% before the Affordable Care Act passed for smaller insurers selling policies in the non-group market for individually purchased insurance. Under Obamacare, the portion of the premium going to marketing, administration, and profits was constrained to 20% for small insurers and 15% for larger insurers. And under a recent proposal, states would have had the freedom to relax those standards, but that was not changed by Congress. He also notes that some students of administrative cost of Blue Cross Blue Shield plans and other private insurers report that number is too high, and they currently estimate the range to be about 9% for the Blues and between 10 and 11% for other private insurers. But back to the formula. This would imply that holding all else constant, a higher loading factor, say greater insurer profits, would lead to a higher premium. And this could be due to reduced competition and therefore higher profits in the health insurance industry, or perhaps due to adverse selection, or simply due to rising administrative costs. Higher coinsurance rate, that is, a greater portion of the bill paid by the patient out of pocket, would lead to a lower premium charge to the insured individual or their employer. And medical care price inflation, that is a higher P, will lead to a higher premium, as would greater utilization, Q, in this formula. So the medical loss ratio for ACA's 80-20 rule stipulates that insurance companies have to spend at least 80% or 85% for large group insurers of their premium revenues on healthcare claims and quality improvement expenses, and the remaining 20% can be spent on administrative overhead, marketing, and profits. And so the medical loss ratio is simply the ratio of spending on healthcare and quality improvement out of the premiums that are being collected, that of taxes and fees. So there's a floor for this medical loss ratio of 80%, or up to 85% for large group insurance. And that was one of the rules and regulations put forth by the ACA. So if you had a situation like we did in 2018, where that medical loss ratio falls below 80% or below 85% for large group insurers, those insurers would have to issue a rebate to those who have paid those higher premiums. Now, to provide a practical example of what a health insurance premium looks like and how it's broken down, data has been collected from the Pennsylvania individual marketplaces and specifically focusing on Keystone Healthcare East over recent years. This is one of the larger insurance plans in the ACA marketplace in Philadelphia. As you can see, that between January 2016 and December 2016, they brought in about $588 million in premium revenue, had $512 million in claims or healthcare expenses, $70 million in administrative expenses, and then $21 million in taxes and fees. In 2016, the company actually lost about $16 million, and because their claims were greater than expected, and they expected medical costs increased by 24%, at that point in time, they requested a rate change for their insurance plans of 21.7% to be effective in the year 2018. And that would be for 150,000 plus subscribers in the ACA marketplace. You can see how they had planned to spend 82% of their premium dollars on claims or actual healthcare expenses, 12% on administration, 4% on taxes and fees, with a slim 2% profit after that. And so we can see here that all else being equal, higher administrative expenses, taxes, and fees results in greater loading factor, and that leads to a higher premium and a higher claims expected average medical expense. P times Q would also lead to a higher premium. The following year, in 2017, we saw that premiums went up, as did claims. But the company's bottom line improved, and they made a profit of $34 million, and you can see where they were expecting annual medical costs increased by like 10%, which is still pretty high for the 2019 year. And then they requested a rate reduction in that case, actually due to the kind of stability in the market that they had faced. In 2018, they made a profit of more than $137 million, collected more than $1 billion in premiums, incurred $710 million in expenses for medical care, $128 million plus for administrative expenses, and then more than $100 million in taxes and fees. And the revised requested average rate change for 2020 was 5.4%. Here is the most recent data for 2021. So in 2019, they also had a profit of $71 million, and going into 2021, they actually had a revised requested average rate change of minus 4%. So premiums were starting to fall as these markets were stabilizing. But early on, the prices were increasing quite considerably. And that might have reflected some uncertainty about the future of the Affordable Care Act and the potential for adverse selection in health insurance marketplaces. But things seem to have stabilized, not just for this plan, but across the marketplace. And more insurers have been entering the ACA marketplace in recent years. Now, let's talk a little bit about risk pooling. When individuals are combined into a large group, everyone in the risk pool pays the same premium, or what's called a community rated premium. Some risk pools are made up of people who have a similar risk of using health services, while other risk pools are made up of diverse individuals, some higher risk and some low risk. Insurance companies generally prefer large risk pools because they can collect premiums from everyone in the group, but only a small percentage of the individuals will actually need costly medical care. Let's take a look at an application of risk pooling. Suppose we have a low risk pool group where individuals in that group have a 4% chance of a $50,000 loss. The expected value of the loss is the probability of the loss of P is equal to 0.4 multiplied by the amount of the loss, $50,000, and that would be a $2,000 expected loss. For a high risk group with a 30% chance of that same $50,000 loss, that would lead to an expected value of the loss of $15,000. Now that these two groups are pulled into a community for this risk pool, and each risk pool comprising 50% of the population, the expected value of the loss and the community rated premium would be the following. We would have 50% of the population in the low risk pool would be expected value of a loss of $2,000. Then we would have 50% in the high risk pool with the expected value loss of $15,000. So the expected value of the loss across those two pools would be $8,500. So this would be the premium that would be charged to both individuals in the low risk group and the high risk group under this risk pooling situation. And just as a definition, community rating is a rule that prevents health insurers from varying premiums within a geographic area based on age, gender, health status, or other factors. So if you're in the low risk group and your expected value of the loss is $2,000 and you're charged $8,500 for that premium, it might make sense to drop out of this insurance arrangement. And this leads to a situation called adverse selection. People who are in good health and expect no major health problems may opt for a less expensive policy or may opt to remain uninsured altogether. And if these two risk pools are combined, the insurance company may end up with an unbalanced risk pool. That is a pool comprised of many high-risk individuals and few low-risk individuals, as those low-risk individuals may prefer to remain uninsured instead of paying the community-rated premium. This is why the Affordable Care Act initially included an individual mandate for health insurance, because the idea was that people who were in that low-risk pool would drop out of the health insurance arrangement if they were being charged a premium that was much greater than their own expected healthcare expenses. And this is something we'll explore further in this week's module, which is a guided worksheet on the insurance market. One study was talking about this potential for adverse selection, and they call it an adverse selection death spiral for the following reason. In an unregulated market, premiums will be risk related. That is, younger, healthier consumers are charged lower rates due to their lower expected claims. Since community rating requires insurance companies to charge the same premium to all consumers, the rate charged to younger individuals might rise in response to the higher cost imposed by older persons with the same coverage. If enough younger consumers react to this price increase by dropping coverage, expected claims for the covered group for the full pool will rise, which will necessitate a further increase in premiums, and in the extreme case, the cycle will continue until only those consumers are left for those who have the higher expected medical expenses. However, empirically, when looking at the effect of community rating on health insurance coverage in New York, for instance, they found no evidence that there was this adverse selection death spiral. So this might be something that we see in theory, but not in practice. Another concept presented in Chapter 8 is that of moral hazard. This refers to the risk that a person might behave differently if protected from the financial consequences of an action, and to reduce the effects of moral hazard or overutilization, insurance companies commonly use coinsurance or deductibles. But they also establish plan stipulations in some cases. For instance, limiting the number of visits per year, and that would require or encourage less utilization. However, if we have reduced utilization of preventive health services, for instance, this could lead to a significant welfare loss or loss in well-being to society if individuals are not allowed to meet their desired healthcare consumption level. But in recent years, we've seen coinsurance and especially deductibles being increasingly used by insurers to economize on their claims expenses. So turning to the supply side of the insurance market, we should note that insurance companies can achieve economies of scale, that is, a falling cost per policy, by selling as many of their products as possible. And selling group insurance does just that. When a group of individuals contracts with an insurance carrier, for instance, through their employer, administrative costs are reduced and spread out across all of the members in that insurance arrangement, and therefore profits for the insurance carrier could increase through the achievement of economies of scale. Regarding competition and the insurance market, we should note that an insurer that controls a large share of the market can greatly influence the premiums and the reimbursement rates that healthcare providers receive for delivering services. So if you only have a handful of providers operating in the Affordable Care Act marketplaces, for instance, they might have significant power when it comes to both the setting prices for premiums, but also setting reimbursement rates for providers in their networks. And market entry can be difficult for a new insurance carrier given the necessity to form provider networks and also achieve economies of scale that would allow them to be cost competitive in those marketplaces. As I noted earlier, the Affordable Care Act initially included an individual mandate to have health insurance that was eliminated as part of the Tax Cuts and Jobs Act of 2017. And so that one part of the ACA has been eliminated. But insurance companies are still prevented from refusing to sell coverage or to renew policies because of enrollees' pre-existing conditions. And they're also prohibited from establishing annual limits on the dollar amount of covered services a member may receive. The Affordable Care Act also led to a significant decline in the uninsured rate, as we saw before, since 2010. And this occurred through expansion of Medicaid in those states that decided to expand the Medicaid eligibility within the framework of the ACA through the development of the ACA insurance exchanges or marketplaces, and also by allowing young individuals to remain on their parents' health insurance plans until they reach the age of 26. Here ends the PowerPoint presentation for Chapter 8, Part 1.